I'm Dr. Mike Milligan. I'm here with Dr. Dennis Abbot from Dallas, Texas, dental oncologist. In other words, patients with cancer anywhere in the body, Dennis is taking care of them both in his practice and in a hospital setting. Dennis, thanks so much for being with us.
Thank you very much for having me.
Well, I don't suppose there are too many dentists out there like you, but we sure need them like you. And tell us a little bit about what you do, what you see, and how you're helping these patients.
Thank you, I appreciate that. There are some others out there, but a lot are not in private practice. And so this is kind of a unique situation. What we do is we take care of the needs of cancer patients before, during, and after their treatment, because the side effects of chemo, radiation, cause some real problems in the mucosa, and not just in our head and neck patients, although those patients we're going to see specific real problems because of head and neck radiation, but any place that the patient is going to have chemotherapy, they may end up with dry mouth, for example, or mucositis, very deep painful sores that kind of become this open pathway into the systemic blood system and can cause some real septicemia and some real bad infections at times that they are immunosuppressed. And so it really ties in nicely with the mission of AOSH in kind of bringing the mouth and the body back together, so to speak.
Absolutely, in a huge way. You were telling me about the division of the cells in the oral mucosa dividing rapidly, and so they're affected by some of the chemotherapeutic agents that are there to treat cancer throughout the body. Can you expand on that a little bit?
Yes, exactly.
And the oral effects?
Sure. So the basement layer membrane of the oral mucosa is a naturally occurring, rapidly dividing cell.
Right.
And so because the cytotoxic drugs that we use in chemotherapy oftentimes are designed to attack those rapidly dividing cells, that's why people lose their hair, we see a disruption of the basement layer membrane of the oral mucosa. That in turn will lead to an obliteration of the layers that are above it, and so we get this very deep, profound sore that we call oral mucositis.
Okay.
And that, just like I said, because it's so deep and so destructive, it often causes a lot of pain. It's inflammatory in nature and can be easily infected with bacteria or fungus or anything else that happens to be living in the mouth at the time. And so, and this usually coincides with somebody who's already having dry mouth effects, so the flora of the mouth has already changed. So we have some real issues there that can become very, very serious health concerns in these neutropenic patients that we have to address and we have to manage.
Mm-hmm. Absolutely. So for the general dentist population out there who don't quite have the training or maybe the population that you have there in Dallas, what should we know and look for, and how can we help our patients in our communities who have not only head and neck cancer, but cancer anywhere in their body? What should we be looking toward to work with our oncologists in our communities?
That's a great question. I can tell you one of the things that is so elementary for a dental professional standpoint, but is so useful, is just getting the teeth cleaned.
Okay.
And so we see that if we can actually reduce the intraoral bacterial load in these patients, that we can significantly reduce not only the incidence of complications like oral mucositis or something like that, but if it does occur, that we can affect the severity of that as well and diminish that severity so it's not as painful or lasts for as long of a time in these patients. So that would be the first thing. I think then in this specific niche group of patients that are going to be undergoing head and neck radiation, for example, those patients we need to make sure that we get them cleared, because once we have had exposure to radiation in the head and neck, we don't want to come along and pull teeth. It's that osteoradionecrosis that we all heard about in dental school. That's a real big problem. And so from that standpoint, in those patients specifically, we should get that taken care of beforehand, get any teeth extracted that need to be done, any periapical pathosis that needs to be addressed, all of that needs to be addressed ahead of time.
Get them very healthy, periodontal, periapical, fluoride trays.
Yes, fluoride trays.
Can you just address for those patients, head and neck radiation? I mean, we all have those.
Right.
I've had several in my practice, and just give us the various things that we really need to be aware of for those patients.
So for the head and neck patients specifically, they are without a doubt going to have xerostomia, and they're going to have it 100%. It's going to be very, very traumatic for them. And so what we want to try to do in the patients that we see that we're going to keep the dentition in,
Right.
okay, is that we want to make sure that we protect that dentition. We want to give them fluoride. We want to try to be able to make sure that we don't have any caries before they go into treatment, because the caries are going to continue to go very rapidly in that
Right.
dry mouth environment. So managing the xerostomia, using some kind of an agent, there are several there that are on the market to be able to help manage that. It is, like I said, an uphill battle with that specific group because it's so profound, but any kind of help in that direction is beneficial for them.
You need to get any tooth out that's got any chance of going bad.
Absolutely.
Periodontally or decay-wise. You need to get the decay treated. You need to get them on a fluoride. You need to get them on a saliva substitute. What are some of them that you like?
Some of the ones that we use in our practice?
Right.
Really our go-to product that we have, that we've found on the market right now, is by a company called MedActive.
Okay.
It's a company that's based in Florida, and they have a rinse and a gel and a spray and a lozenge in their line.
Okay.
And it has, it's a patented product called an ultra emulsion, which is kind of like a wetting agent.
Ultra emulsion? Okay.
Which is like kind of their patent name for their wetting agent in there. But the thing that I really like about it is it has a 0.63% stannous fluoride,
Okay.
which is going to help with the bugs. And then it also has a plant extract called spoanthol in it, which actually stimulates salivary function. And so even though major glands have been affected, if there are any minor that are still functioning, or if there's any possibility to have that, as the patient sometimes begins to get salivary function to return,
Right.
that product can really help.
Okay.
We've also had one that we like that's called, it's by a company called Perio Sciences, which is a Dallas-based company.
I'm aware of that.
Yeah, and they have their gel, the AO gel,
Okay.
using the antioxidants there, and we're not really sure exactly why it happens, but we've found that a lot of patients will get some relief from the dry mouth just by
Okay.
using the gel.
Okay.
So, and that was kind of a serendipitous finding that we found whenever we were using that product in treating some other conditions in the mouth.
Okay. What's the ability of the mouth to regenerate and not need so much saliva substitute? Does that happen over time, and over what time frame? Or?
Yes, yes and no. Okay, this is one thing that makes what we do very interesting,
Right.
and it's all individualized.
Right.
And it's going to be dependent upon the dose of radiation, what anatomical structures were in the radiation field, how much radiation did the product get, how much radiation did the sublingual or submandibular gland get. And so all of those come into play. Some people will resume salivary flow, but some people may not. And we actually have people who have survived particularly head and neck and oral cancers for 20, 25, 30 years,
Right.
and they were treated with a different type of radiation. They were treated with conventional beam radiation, where it was just kind of like this big blast, as opposed to the intensity modulated radiation therapy that we have now. With IMRT, it's very focused.
Right.
And while the radiation oncologist will still need to treat the glands to some extent, because that is an area that metastases like to go to, we can a lot of times spare that enough that salivary function will return at some point. And again, we're seeing now, particularly in head and neck patients, a much younger population getting these types of cancers because of HPV.
Okay. The HPV.
And so the HPV virus. And so I'm actually seeing patients in their 20s and 30s in my practice that have oral cancer and are having to be treated with head and neck radiation.
Right.
The answer is not to slick these patients or to take out all their teeth, because we have to account for quality of life and function as cancer survivors.
Absolutely.
Yeah.
Right. Fluoride trays. Now, let's speak about that a bit. You want to get the fluoride trays so that the patient can use those. Let's talk about the frequency. Let's talk about the type of fluoride you like. I've even had some oncologists, one in particular, asked me to make a tray that the patient could put on their mouth to protect their teeth during radiation.
Absolutely. Yeah, that's called a radiation stent.
Okay.
Yeah.
So if you can talk to us about those things, let's get that aspect taken care of here.
Sure. The fluoride trays are, just like we would use any kind of tray, like a whitening tray or something like that. And we ask our patients to use them every day. That they're going through the treatment, and that is as much as they can tolerate. There are going to be times when maybe some of our head and neck patients may not be able to tolerate it as often, just because of the sensitivity in the mouth, but we try to get them to use it every day I tell them if you can use it for 10 minutes a day, I'm good with that.
10 minutes once a day.
10 minutes once a day. Put it in when you're taking your shower. Put it in when you're watching the news. Make it something that becomes part of your routine. We typically will use the Colgate Prevident 5,000 parts per million fluoride, the dry mouth formula. It doesn't have any sodium lauryl sulfate in it, so it's not very antagonizing to the oral environment as far as in that type of a condition. But that's the one that we use. But any of them will work with what we're doing. That's the one that we have. Yeah, I've had people ask me about what about MI paste and this, and all of those are fine. So whatever is the dentist is comfortable using.
Okay, and do you want to start using these before radiation treatment, and how long before, and then how long after?
Absolutely, and so our rule on that is, if we can get them in before and begin using the trays, then we're already beginning to have that beneficial effect of the fluoride in place. Then they go into treatment, they lose salivary function.
So a few weeks before, a couple days before, what are you talking about?
It depends on when we see the patient.
Okay.
A lot of times we'll see the patient.
What's your preference?
As soon as they're diagnosed.
Okay, as soon as they're diagnosed, get them on that fluoride, get that work.
Absolutely, absolutely. And so we're fortunately in a situation where many of our physicians that refer to us do make us part of that. Now you're going to see this person and this person and this person, this doc, and this doc. And so we do have the benefit of seeing these patients very early on. We try to get them started on that right away, get the teeth clean, get them on fluoride trays. They need to use it until salivary function returns.
Okay, and if it doesn't return or it only partially returns, they need to stay on this
that is right.
At least 10 minutes a day if they can possibly do that. Do you like them to do it more or not? If they could do it twice, 10 minutes a day.
If they could do it twice, that's fine. Okay, but we're going to get the benefit there in 10.
In 10 minutes?
Yeah.
Okay.
Yeah. At a 5,000 parts per million, we're going to get the benefit there.
And when do you use the tray during radiation? And that's
Sure.
a thicker tray
Yeah.
that you have.
It is. The radiation stent, we do try to make it a little bit thicker. It's not quite as thick as a mouth guard, but we want it to be a little bit thicker,
but a
obviously,
thick
than
mouth
a
guard
fluoride.
type material. I think we use the 3 or 4 millimeter.
Exactly. Yeah.
Thickness.
Yeah, it needs to be 3 to 4 to 5, in that range. Something as thin as a fluoride tray was not what we use. No. Here's what happens with the radiation. Even though the radiation is going to pass through anatomical structures, it is going to scatter. And if the patient has amalgam or gold restorations that are adjacent to the buccal mucosa or to the tongue, it's going to create a burn. And a mucosal burn in a dry mouth environment is very painful and very risky as far as getting an infection, okay? And so what we try to do is we try to create that barrier between the metal that is going to scatter the radiation and the mucosa or the tongue to try to provide some protection for the patient there.
Okay. So we've talked about fluoride, we've talked about the sialagogues, we've talked about getting the teeth healthy, getting the teeth out that are not healthy. What else do we need to do for these patients?
I'm going to go back, sorry, and I'll tell you, but there's one thing that I want to make sure that the dentists out there understand about the radiation stents. The radiation stents must be made prior to the patient being fitted for a mask. In the case of head and neck radiation, the patient is going to have a face mask on that adheres very, very tightly to their face because they have to be positioned in the same place each and every time they go in for radiation. The measurement is so acute in that situation that if they don't have the stent, the radiation stent in place when the mask is made, there's no room for it to be in the mouth. So that needs to be done prior. Now, as far as the rest, as far as taking care of the teeth, taking care of the periodontal health and all of that, again, in a dry mouth environment, we're going to have a lot of opportunistic infections. We're going to see Candida where we might not normally. These patients are going to go through immunosuppression, and so we need to make sure that we're fully aware of their ANC and their platelet count. We don't want a neutropenic or a thrombocytopenic patient in the chair having either an infection or a bleeding episode that we were responsible for. So we constantly communicate back and forth with our physician colleagues to make sure that we have the labs that we need. If I don't see the lab, and by current lab, I mean it needs to be taken within the week that I'm going to be seeing the patient. So labs that are a month old are no good to me. And so if I need to order blood work, I'll order blood work. But these patients are usually getting that done all the time. So again, these are the kinds of things that we have to be focused on and be responsible for, because now, I mean, we really are moving out of this dentist tooth kind of guy into this partnership with these physicians to be part of the systemic health of the team for the care team for this patient, and we have to make sure that we protect them and keep them safe. So it's a lot of things. It's communication back and forth between the physician and our office. It is taking care of them as survivors and needs of survivors, trying to help, especially in our head and neck radiation patients, understand that swallowing may be something that is difficult, because a lot of times they're going to be placed on a PEG tube, trying to be able to refer them to a proper speech therapist or speech pathologist that can help with swallow therapy. Those kinds of things are things that we have to look at for quality of life and for health for these patients as survivors.
Is there anything you'd like to tell us about, we really hit the head and neck patients. Anything else you'd like to tell us about those that have cancer in other areas of their body, the effects of that and what we should do?
Yeah, and I think the biggest thing that we have to look at beyond just the general dry mouth or mucositis, which we've already talked about, are the patients now that are on bisphosphonate therapies.
Right.
These patients have metastases to the bone. Their primary may be located in breast, it may be located in prostate, but now they have metastatic disease in their bones.
Right.
And so one of the drugs that is commonly used is Zometa, the other is Iridia, and both of those are bisphosphonate drugs. The bisphosphonates remain in the mineralized matrix of the bone for a half-life of decades, so basically for the remainder of the patient's life. And it kind of comes with the same type of stipulations that we have for our head and neck radiation patients. We don't want to do extractions on these patients.
Right.
We don't want to do implants on these patients. We don't want to do anything that's going to expose or affect the bone, because it's going to cause an osteonecrotic event.
Right.
There's another drug on the market now called Xgeva. It's a monoclonal antibody, also called denosumab. There's a shorter version of it that is called Prolia, that's used to treat osteopenia. Those are important drugs that dentists need to be aware of, because even though they can cause those same type of problems, if the patient has not had a history of bisphosphonates, they can have a drug holiday from that one, and we could do a surgery and then come back on the drug. But all that has to be coordinated with the oncologist.
Dennis, what else would you like to tell us before we close?
I think that the main thing that I would like to stress to the dentists out there is that you really are an integral part of the care team for these patients. And you have to sometimes step out of your comfort zone and step out of the box, make the calls to the physician's office, be an active member of that team, and present yourself as the expert in the mouth, because that's what we are. And unfortunately, our medical colleagues and the docs that I work with all the time will be the first to tell you, we don't know, we're not taught that in medical school, and we are. And so we have a place at the table. We need to be a part of the treatment planning and the care teams for these individuals with cancer.
Where do we get more information?
So you can check out our website.
Okay.
Our website is www.dental-oncology.com. It's kind of hard to say all the W's. So dental-oncology.com.
Right.
And then also I have a speaker site, drdennisabbott.com. And I lecture a lot, and so if patients are interested, or if doctors are interested in learning more, they might want to check out some of the lectures that we have going on. We'll have more coming up in 2015 that will really begin to address more of the whole dental oncology as a broad scope.
Wonderful. Dennis, thank you so much.
Thank you for having me. I appreciate it.